We would like to introduce our moderator, Diego Kamenker with HL7 International. And then momentarily our first speaker as part of our panel will be Ryan Howells. He'll be sharing an introductory screen for the panelists. We're really pleased this afternoon to have Ryan Howells, Amal Vaez, Pat Taylor, and Frank McKinney with us. So Ryan, I'm going to go ahead and hand it over to you and you can begin sharing your screen.
Great. Thank you so much. I appreciate it. Hopefully everyone can see my screen okay. We appreciate the opportunity to chat with you today a little bit about the work that we are doing in the CARIN Alliance. And I, along with my colleagues here, will be talking about that in more detail. We actually have 2 sessions today that are scheduled. Today is going to be an overview session of the work that we're doing in CARIN. Unlike some other FHIR accelerators, CARIN actually plays a role in both the policy world as well as the technology world. So we're going to share a little bit about the work that we're doing in both areas and some of our latest thinking around that. And then tomorrow we have a Let's Build session. We're going to get much more in detail in regards to showing Blue Button and the connectivity associated with that. And for folks that actually want to connect, they can be able to do that. And also talking a little bit more in detail about UDAP and how it relates to SMART and some other things related to registration authorization. So just so you know the kind of the perspective of what we're taking over the next couple of days here, and we're excited to be able to present. So for those of you who don't know, I think most of you do though, the CARIN Alliance was formed about 4 years ago, specifically to find ways to really rapidly advance that ability for consumers and their caregivers to get, use, and share their digital health information when, where, and how they want to achieve their goals. Our focus is exclusively on business to consumer data exchange and trying to remove the policy and business and operational and technical barriers to making that happen at scale. We are very pleased to have a number of industry leaders that are helping us in that effort. We have 7 of the 10 largest health plans in the country, a number of different Blues organizations, including the association who's going to be speaking with us later today, as well as the EHR vendors, the major EHR vendors, either directly or through their association, and a whole bunch of consumer advocates and third-party applications and others. A real multi-sector, industry-led and consumer-led, I should say, partnership related to how we find opportunities for us to advance the ability for consumers to be able to get access to their health information. We want to find ways to make that happen at scale, and are excited to be able to share with you a little bit of our thoughts today around how that should work. One of the first things that we tried to tackle in CARIN was this ability that when consumers get access to their health information through a third-party API via an application of their choice, that application is outside of HIPAA, and that is actually under the Federal Trade Commission jurisdiction. And the Federal Trade Commission basically enforces the terms and conditions of the individual app. And so for us, obviously, and for all consumers around the country, that is very problematic because different apps will obviously take that information and use it in different ways, and unfortunately, sometimes nefarious ways. And so what we needed to do is to find a way in which we could come up with a common set of best practices for how those apps should actually use that data in a common way. This would be a voluntary attestation to a set of key principles for how these apps should actually use the information. But we felt as though it could be an opportunity for us to at least set an industry standard. And in talking with the FTC and obviously some other private sector partners, the good news is that this is an opportunity for us to come together as an industry, as well as from the public sector side, and to be able to help to enforce these set of principles. So that is what we call our CARIN Code of Conduct, which is on our website. And our hope is that when an app comes and goes through the registration process and actually is able to get the the OAuth client secret, they can be able to receive that information, but in doing so, they can actually be able to attest to the CARIN Code of Conduct, which is that baseline set of principles out there, so that when someone comes in to register, when the app comes in to register, they can be able to attest to that code. That's super important. In addition to anything else individual organizations want to do to register the apps, because it does actually set a ground level minimum set, a bar, so to speak, on how those apps should actually handle the data, which is important for us as an industry if we're going to be able to start to share data with entities that are currently not covered by HIPAA. The second kind of foundational stage in our trust framework is what we call the kind of the questionnaire. We also have called this the nutrition label phase, which is how does a consumer start to digest this information in a common way across platforms? How can they start to look at this information that's actually found in the terms and conditions of the app, as well as what is located in the CARIN Code of Conduct, and be able to start to digest it in some type of a common user experience or user interface, so that they can be able to make informed choices for themselves and their family based on how they want to use, manage, and share their own information. And this is important, and that's really where we are right now in our approach to CARIN. We're going to talk a little bit about some of the progress we've made there. And then the third phase is optional in the sense that it's outside of CARIN's purview, but we are working with independent third-party validators like ENAC and others to be able to come behind us and to validate not only what is found in the CARIN Code of Conduct, but also is found and what the apps actually answered in their questionnaire, to actually validate that they are doing what they said that they would do. And so we anticipate a whole series of independent third-party validators to come behind us to be able to validate that information. Most recently, just in the last month, we have launched what we call myhealthapplication.com. It is a vendor and platform agnostic tool website that actually provides an opportunity for consumers to go there and to find an app of their choice that actually is going to aggregate their health information for them, and in a very transparent way provides also links to their privacy policy and terms and conditions, and what platforms are being supported as well. And again, who has attested to that CARIN Code of Conduct. We anticipate that we're going to have a lot of different affiliations for these apps, which we're still working on, in addition to the CARIN Code, and a few of those are out there now, but we also anticipate at least that this will be a foundational point where consumers can go, and they don't necessarily have to go into an EHR store or into CMS Blue Button. They can go to a common location that really is able to say, here are the apps that actually have connected and can be able to aggregate data on your behalf. And we also think this is going to be a launching point for where those independent third-party certifiers can also be able to show that they have certified these apps in a way that is consistent with the CARIN Code as well as under industry standards, and so that individual consumers can start to build trust in an ecosystem in a way that is, again, consistent with their needs. To make that happen. And so eventually we see this as growing into also potentially having the opportunity for a technology play too, that allows for each of these apps to receive individual, for example, tokens that have actually been certified by these third parties and be able to access the information that they need on their behalf. So there's a lot to be developed here over time, and we're excited to roll that out. So let's talk about the CMS Final Rule, which I'm sure everyone has read on this call, and kind of how that relates to the overall ecosystem. We are part of the HL7 ecosystem and the FHIR Accelerator ecosystem, all of those different ecosystems, and we're looking at ways where we can work together to try to help payers and others be able to meet the needs of the final rule. This is a flow chart that is has a lot more behind it. And so we encourage you, we'll make these slides available to study it closely. I'm just going to touch on a few different points here, which is if you look at just the patient access API requirement, the ability for a patient to be able to aggregate their clinical and claims information, there's other requirements in the rule itself. I think the first thing to note is here in the bottom, which is there are no required HL7 FHIR implementation guides that are mandated by the final rule. really what this slide is doing is just trying to suggest options for the industry to use to make this happen. But from a flow perspective, the data comes out of the provider systems of record and would go into the payer systems of record in both their clinical and their claims systems. For a patient that is currently a member of a given payer, they are going to be able to request their claims information, and they can do that in an R4 format. And they can use the CARIN Blue Button implementation guide that we're going to talk about here to actually manifest and be able to engage in that transaction. They can only request their claims information from their current payer. They cannot request that information from any prior payer that they have. And then, so that's from a clinical and a financial perspective. From a, that's from a claims and financial perspective. From the clinical perspective, they can request their information from their current payer using a series of different options. They can use US Core R4, they can use DaVinci PDEX, and they can also use the clinical information from another optional source, like for example, the common payer consumer data set, the clinical data that actually would come from that section. And then for the drug information, they can, DaVinci's PDEX IG can also be used for providing that drug information to the consumer using that single OAuth request. For payer-to-payer data exchange, they can be able to make that request of their current payer and be able to have their current payer go and actually request that information of a prior payer. And they can use that information and exchange that information. The payer can exchange that information with another payer using really any format that they would like according to the regulation. DaVinci's PDEX format is actually there and available for the payers to use to actually make that transaction and send that clinical information over. And so, but it is up to the payer as to what type of information that they, what format I should say that they use. Again, there is no API requirement for a consumer who is making the request to get clinical information from a previous payer for how that payer should send that information to the other payer itself. And we're going to talk about that in a little bit more detail. The other kind of nuance point here, especially with the rule, is that if a previous payer sends this information to a member's current payer, and they send it, for example, in a PDF format, the current payer can send that information to the member in a PDF format as well. They can send it in the form and format that they had received it from the prior payer for up to 5 years after the disenrollment of the individual member. So a lot of nuances here, just touched on a few. Obviously, make sure you reach out to your individual legal departments to be able to clarify these things as part of the rule itself. So with that, I want to turn it over to Pat Taylor from the Blue Cross Blue Shield Association.
Okay, thank you, Ron. The Interoperability and Patient Access Final Rule was published May 1st. It delivers on the administration's promise to put patients first, giving them access to their health information when they need it most and in a way they can best use it. CMS provided this timeline, taking us from March 2018 with the launch of Blue Button 2.0 for Medicare beneficiaries through April of 2022. Today we'll focus on data requirements for 2021 and 2022. By January 2021, next year, at the request of the member, payers are required to provide 2 APIs for use by third-party applications. The APIs are the Patient Access API and the Provider Directory API. Note that while the effective date is January of 2021, enforcement is effective July 2021. By January 2022, again at the request of the member, payers are required to exchange patient data with other payers. The CMS rule applies to the data that insurers have for programs that CMS manages. There are 4 programs. It's Medicare Advantage, including Part D, pharmacy, Medicaid, CHIP, or the Children's Health Insurance Program, and QHPs, or Qualified Health Plans, offered through the Affordable Care Act, federally facilitated exchanges. Note that a payer is not required to provide data collected through other lines of business. For example, our understanding is that a payer is not required to provide data about a member covered under a commercial policy. However, there is nothing preventing a payer providing the data should it wish to do so. As Ron explained, the Patient Access API delivers 3 types of data: the CARIN Blue Button data, the clinical data, and Part D formulary data. We'd like to focus on the CARIN Blue Button data, the claims, EOB, or explanation of benefit data. Can you go to the next slide, please? The Common Payer Consumer Data Set, or CPCDS, is a set of data elements that should be accessible and available for payers to provide to members. The data elements are similar to the set of data elements that meets the CMS Blue Button content. CPCDS defines 123 data elements. Once defined, the next step was to map the data elements to FHIR. And at first glance, the FHIR standards can be overwhelming. With the assistance of a FHIR SME, the team mapped the CARIN data elements to FHIR. And the CPCDS data elements can now be stored and queried as profiled FHIR resources. A guiding principle for the mapping was that it aligned with claims submission standards adopted by the Department of Health and Human Services. The results are profiles, explanation of benefit profiles, specific to whether the claim was submitted as a facility, professional, or retail pharmacy claim. Payer claim submission standards require specific sets of codes. You'll hear terms such as CPT, describing medical procedure codes, ICD, describing diagnosis codes, or NDC, describing drug codes. Licenses to use the codes are required by many organizations that own the codes. For example, the CPT procedure codes are owned by the American Medical Association. The CARIN Blue Button IG will include intellectual property verbiage provided by the HL7 Terminology Authority. The result is an implementation guide, the CARIN BB Guide, CARIN Blue Button Guide, defining how payers are to provide the claims and encounter data. The guide satisfies the use case for member access to health plan data, ensuring the CPCDS data elements are included and modeled in a standard format. As a suggestion, the CMS regulations and guidance on interoperability links to the CARIN Alliance Blue Button framework and CPCDS IG, noting that it is currently in development. So I'll turn it to Hamal, who will talk more about the CARIN Alliance.
Thanks, Pat. With that introduction on CPCDS by Pat, I just want to kind of circle how the CPCDS kind of came into being and what was the inspiration behind that. So the CPCDS is really modeled after the best practice approach adopted by ONC Common Clinical Data Set, or its latest incarnation, US Core Data for Interoperability version 1. The idea there is to provide a common model or a data set that represents the claims or adjudicated claims data at a payer. And CPCDS basically started out with using the CMS Blue Button 2.0 API data model as its first version. version from CMS Blue Button 2.0 API was expanded and tweaked to allow for commercial payers through a series of consensus meetings that we had under the CARIN Alliance work group. And we really hope that the CPCDS in its current version represents the majority of the elements most commonly used under a payer's claims adjudication system. The data element consensus obviously is ongoing, and it is very important for us to look for feedback and comments to make it better. Next slide, please. This slide kind of talks about the relationship between another standard used in the claims world, which is EDI X12. The EDI X12 is really what starts the ball rolling in terms of claims and claims adjudication. After the claim is received and adjudicated by the payer, in this case the health plan C, the record for adjudicated claims is created within the health plan's systems. In this case, you're seeing a couple of systems at the health plan C. This might represent a merger that basically brought the two systems of record, facets here and some other system of record, together under a single health plan, or it could be different lines of business that have their own systems of record. The objective here is that the CPCDS allows a payer to express its adjudicated claims data, regardless of how it is present in their system, in one or many systems of record, as a single unified data set. With that representation, a payer is able to map, leverage the CARIN mapping to map the claims data set to FHIR CARIN Blue Button profiles. So it basically provides a payer the blueprint to create the profiles that will be exposed through the CARIN Blue Button API. Next slide, please. This slide basically lists out different reference materials as far as the CARIN Blue Button, starting with the CMS guidance on their recommended technical implementation guides that payers could use to become compliant. The first link is very descriptive and talking about the specific implementation guides for each of the patient access and other components of the final rule. The following links are they point to the balloted version of the HL7 balloted version of the CARIN Blue Button implementation guide, and some of the ballot reconciliation activities that are going on right now with respect to that IG. There is a hyperlinked URL in the JIRA as part of the third bullet that folks can kind of visit to see what active tickets exist as far as the ballot reconciliation process. We invite folks here to take a look at the existing tickets, and if there are any questions or comments, feel free to respond to us to make the IG as good as possible when we go to publishing. There's also a CARIN Alliance homepage on HL7 Confluence site, which folks can visit to see the different documentation and materials that we have available. And again, we welcome feedback on the material there so that we can make the material as refined and unambiguous as possible. And as a heads up, there is going to be a virtual connect-a-thon a CARIN Virtual Connect-a-thon tentatively planned for August, details of which will be published through various channels. And folks might want to kind of plan for that as they are preparing, especially for the CMS deadline of 1/1/21. With that, I give the control to Frank.
Thanks, Kamal. So I'm going to talk a little bit about another effort that CARIN is sponsoring around consumer access to information. In this case, it's more on the upfront side versus Blue Button, which is more after the fact information about claims that have been processed. So the consumer facing real-time pharmacy benefit check, it has to do with getting information at the time that somebody gets a prescription to help them understand how much that's going to cost them, whether there are differences in pricing between pharmacies that are near to them, whether there might be alternative medications that they would want to discuss with their prescriber, and whether or not it might actually be cheaper for this medication to be filled and paid with cash as opposed to going through their insurance. The basic process of this is very similar to something that's been developed for use during the prescribing process. And so the background around this is that there is in place now a CMS Part D drug pricing final rule that will require provider-facing real-time pharmacy benefit checking to be offered for Part D beneficiaries. There is currently in process proposed technical changes for Part D that would also require this kind of capability to be available to consumers by January 2022. So because the basic goal of this process is very similar to what occurs during the prescribing process, which is to understand the cost and coverage aspects for a medication, just kind of changing the context of it, and then also thinking through it a little bit further from the perspective of a patient versus a doctor. We wanted to keep the basic flow compatible with that of the provider-facing messaging, while enabling it to kind of adapt and evolve, really focused on the patient as the user versus a prescriber. And so the basic flow you can see here on this slide shows that the application that is intended to be used for this is going to be a consumer application. It could be a smartphone or a web app that will gather information about the prescription that the patient wants to get information about. It'll gather the information to help identify that person's insurance coverage so that it can be requested of their insurance. And we see those as sort of the prerequisite steps. And then at that point, there's going to be one or two requests to gather information. The main path maybe is the request to their insurer to find out how this drug will be covered under their pharmacy benefit, whether there's prior authorization required, for example, or other restrictions. And then what is their copay? What's their cost going to be? With regard to the second flow, it's about understanding how much would this cost if I paid cash, and are there discounts or other programs available that might make that a cheaper option. So as we move to the next slide, we'll just talk a little bit more about those flows and the information that are part of those. So again, we tried to be, as compatible as possible and make this as much of a one development effort kind of request, whether you're going to an insurer or another pricing source that has information about that medication. So the basic information sent in the request is, just enough information about the medication and the quantity that you can use that as a basis for understanding coverage or pricing. Some basic information about the patient, the intended pharmacy, and the insurance. And then the insurer takes that, identifies the patient's insurance record, and determines the response. the same basic information goes in the second flow, which is to a pricing source, with the key difference that coverage information really isn't a part of it, though there may be some identifier that can be sent that helps clarify, the pricing, source, and maybe other aspects that will come into play as people start integrating this. And then the next slide just gives sort of an overview of how that maps into FHIR. So on the request, we modeled this after the predetermination claim and claim response messaging in FHIR to try to use something that's been established, just extending it a bit. So the request is what you would typically see in a predetermination claim. You got the patient, the medication, the pharmacy practitioner. And on the response, it's essentially the same as a regular predetermination response, but it's been extended a little bit to include some information about alternative medications and pharmacies. So you'll get an answer on the particular drug and pharmacy that you request, but the responder might also give you alternatives. Down the street, it's a little bit cheaper, or if you go through mail order, it's cheaper, or this other medication is also typically used to treat your situation, and that might be something to talk to the prescriber about. So that's the basics of it. And I think we're going back to Ryan now to talk a little bit more about the security aspect of this.
Awesome. Thanks, Frank. I just want to talk about identity. I know we just have a few minutes left, so I'm going to go fairly quickly. One of the other projects that CARIN is working on is digital identity. In healthcare, we call it patient matching, but we are actually flipping that on its head. Patient matching means I, as an individual, have to go and identify myself at every individual organization that I have a relationship with. Digital identity means I, as an individual, can take my own digital identity credential and take that credential to multiple different organizations at my own request and behest, and then be able to authenticate myself and, more importantly, identity proof myself with that credential and use that credential across systems. So we had a summit last year where we talked about 5 different aspects of just identity overall, where we talked about the NIST standards, which this group will appreciate, and I hope will read the NIST 863-3 standards, and talked about the fact that we really want that implemented across healthcare, because if every provider and health plan in the country can provide and support, provide or support, I should say, an IL2 certified credential using the NIST guidelines, then we can be able to have a person-centric digital credential to then be able to log into various systems at scale in healthcare. We want to strengthen authentication as well. We appreciate what the ONC has done in referencing the NIST standards in the TEFCA requirements, specifically the common agreement requirements, and want to make sure that that is continuing for both health plans and providers in a meaningful way. Just moving ahead here, digital credentials are already with us. They're already out there in the marketplace. So mobile driver's licenses are in 14 states, either in production or in some type of a test, some type of a pilot, I should say, related to that. And so these digital credentials, again, is not a number. It's not an actual physical number. It's a series of what they call authenticators that proves that you are who you say you are. This is a government issued, obviously, driver's license that provides that digital credential information. And
we do have 5 minutes, Ryan.
Thank you. And that information can be provided and sent electronically or digitally to a third-party endpoint. What we are doing in CARIN is we're going to develop a set of open contractual terms and conditions on a consensus basis for what are those contractual terms that need to exist in order so that we can federate digital credentials using OpenID Connect. That is what's in that blue crescent at the top. We're going to have independent certifiers behind us, names that you may be familiar with, to be able to certify that individual organizations are actually following those set of open contractual terms and conditions. And the combination of those two things will allow us to have a federated digital infrastructure that can be supported in healthcare. So we have person-centric digital credentials that we can use rather than having institutional centric credentials that need to be used anytime that we actually want to receive our data from multiple sources. This is a little bit about our Tiger team and some of the participants that are in that effort, as well as some of the work that we're doing with the World Economic Forum, with multiple countries and multiple industries that are working on a similar problem. What we have found is in the United States, digital identity isn't a hot topic yet, but in other countries and in other industries, it is, and it's actually advancing at a very significant pace. And so we want to learn from those other industries and those other countries and pull those learnings into healthcare in the United States. So with that, here is our information and HL7 website. And Josh, we're happy to take some questions from the group.
We have
right,
3 questions. We have 3 questions in the session Q&A for you. One of them is, health plans have to map from US CDS to IPA 5010 format. Example for claims transactions. This is what he is asking for.
Pat, I'm not sure we understand the question, Pat. I don't know if you...
Yeah. Could you repeat the question, please?
Health plans have to map from CPCDS to IPA 5010 format?
No. What we're saying is that payers, as Amal explained, typically receive data on the, according to X12 standards, 835s, 837s, response 835s. When we defined the CPCDS data elements and mapped in the FHIR, the standards we used were the CMS 1450, 1500, and NCPDP. We did not use X12 as using X12 requires a license, which the CARIN Alliance nor HL7 have. Both organizations are in conversations with X12, but the intent is to use standards to map your claim systems to FHIR, under the standards adopted by Department of HHS. The paper standards and the X12 standards align to the degree that one claims adjudication system, can process both of them. So no, it's not a requirement to map to the CMS 1500 at all. We were trying to explain the background that guided us in terms of mapping the CPCDS data elements to FHIR.
We do have 1 minute left.
There are 2 more questions that maybe you can revise in the session questions and answers, so you can answer later. The other one I have is there are no examples of claim transactions. I couldn't find them in the implementation guide.
Amal, the updated implementation guide will have examples. We're working on that as we speak.
Perfect.
Right.
That was another question.
I did see, just really quickly, there were questions about CPCDS versus US Core. Those are 2 completely different things. US Core is for clinical data. CPCDS is for...
I answered that, yeah.
Okay, great. And then there was a question about state Medicaid agencies who are under the same regulations as the other CMS payers, including Medicare Advantage. So state Medicaid agencies can be able to use the CARIN Blue Button IG to meet some of the requirements for the Patient Access API.
And I do apologize, we are out of time. So thank you to the speakers and to the moderator. And for those of you attending, please do note that the Q&A will be persistent after the call. So if you did ask something, or if you're typing something right now, the speakers and the moderator will be keeping an eye on that afterwards, and we'll make sure that you get those answered. And please check your agenda on the Whova app to get to your next call. Thank you guys very much.